feel like we're in a bit of a pressure of a timeline, and so I'd like to start our conversation this afternoon. And we'll be closing this part, the path forward, at 4:30. Again, I want to thank everyone for attending and for both the Constitution Project and George Annis and his team for organizing this. There are some people who are going to be leaving early, and again, thank you for your attendance. And hopefully we can reconvene. And George, right? It's on your dime. We can reconvene and see if we can follow up with some substantive action. This panel is a free-for-all, and I'm going to make sure it'll be refereed a bit. But it really is to kind of open things up and look at, use the wisdom and experience and the intelligence of this group that's convened for what are your best ideas for what we should do to move forward, and in a very timely way. My totally personal feeling is that I am very worried that what could have been the important lessons of our conversation here and important lessons and implications for military medicine over now 12 years of war could in fact be quickly lost and pass the dust. There is a sentiment, as you know, to put everything behind us and to move on. And I think that is, we see it in the public political debate. And I feel that what that will mean is that important lessons for healthcare providers, practitioners, will in fact be lost. In the near next couple months, there are some opportunities for the opinions of our professional groups and individuals to come out as the Congress debates the National Defense Authorization Act. And there have been some issues brought to the Senate about the future of medical care at Guantanamo. And perhaps some of these issues will also come out as the Senate Intelligence Committee decides if it's going to disclose its full report of 6,300 pages, which I have not seen. But one can assume that in such a study, it costs $40 million, that there's something about health care in that study, and that would be important to us. So I think that we could make a statements individually, collectively, of that would be help influence policy and help influence practice. My feeling is, as I think about what we do here, those of us particularly involved in either directly with detainees in Guantanamo, or those of you who are academic scholars and thinkers, goes to that quote from Edmund Burke that all it takes for the continuation of evil is for good men and women to do nothing. And I think it becomes responsible for us to think about what action we can take. As long as I've been involved with this, I continue to feel shocked that in just 2 generations, from the Nuremberg trials and the first trials of the physicians where we condemned torture and condemned these practices, that we are now sitting down and talking about the involvement of healthcare providers and interrogations, enhanced interrogations and torture, and in practices that fundamentally, many of us feel violate our medical ethics. And that is a commentary on really how things can come out of our consciousness in just a short while. And perhaps another reason for us to look at what we can do very directly. In this panel, we have a number of people, and there are a number of issues that have come out. What I'd like to do first is call on each one of our panelists for their remarks, about 8 to 10 minutes, and perhaps present a question, but I really defer to them in terms of what they're saying. Our first is Captain Shimkus, retired at the U.S. Naval War College. He has to leave at 1600, 4 o'clock, and so I would like to call on him first. And I think particularly his experience as a former commander in Guantanamo and as a professional officer and now teaching understands what the pressure points are, what the responsibilities of commanders are, what the command climate is there, which we have not really talked a lot about, what the detainees are like, which we also have not talked a lot about. So I'd like to first turn it over to you.
I've been a member of the task force now since its inception, I think about 2.5 years ago. And when Len Rubenstein invited me down to New York to deal in the first discussion of this process, I must tell you that being the only one who had been on Guantanamo at that point and been in a position of responsibility, I was somewhat intimidated by those people who were around the table with us and talking about issues in which they had a direct involvement with in the context of doing the right thing. And as this situation has matured and as the committee report has been published, I believe everything that the report published on the 4th of November has demonstrated is that there has been a lacking within the context of our medical profession in the context of Guantanamo. And what I would like to suggest is, being now someone who is dealing with the future line officers, general and flag officers of tomorrow in the U.S. forces, is to do something very simple, and that is to keep the human being, the patient, in the middle of the discussion. And when we put the patient in the middle of our discussion, and we put that patient in the context of a Guantanamo, but still considering that patient to be a human being and deserving respect, trust, and dignity that is part of his being a human being, the decisions become rather simple then in relationship to the path forward. If we believe the tenets of do no harm, and we believe that we are also serving our country, but primarily we are obligated to do no harm, the path forward is, in my view, rather simple in the context of that patient-physician relationship. And regardless of where that occurs, has been demonstrated beautifully by the previous speakers, we attempt to do the right thing. And so my suggestion for us and for those of us who follow us in this context is to simply keep that patient in the middle of the equation and make decisions based on what's best for that individual human being.
Okay, so thank you, Al. I think we'll have some follow-up on that conversation because of the uniqueness of this patient population that has not been discussed much and their particular experiences. Let me just refer, though, to one thing in terms of what you've said. Following the Latif case, Vince Iacopino from PHR approached me, as many of you know, and asked about if I had what my experience, and we talked to other physicians, had been in reviewing the medical records about the kinds of histories and examinations that we customarily do with other patients if we had found those recorded in those medical records. And in fact, we had not. And what we had done, and we published this in the following year in Public Library of Science, we had found what would be otherwise have been items that indicated abuse or people who had suffered some harm and or that had anxiety, sleep problems, the kinds of things that we typically associate with PTSD or other psychiatric disorders, that they were not well documented in these records and had been overlooked, as well as some physical trauma. So in terms of your point, Al, what we're seeing, at least in terms of what's been available to us, is that the standard of care as we know it, day to day, for whatever reason, is not documented. I'm not saying it's not occurring, it's not documented. There may be many reasons, because there are certainly difficulties in establishing rapport with this population, where doctors come in uniform, in the same uniform that they have worn in the combat theater, and now seeing individuals who were more like the people they saw in the combat theater than in their communities, neighborhoods who they serve with. And then the patients are seeing doctors who are wearing the uniforms of those who had also been previously members of the interrogation teams. It's very difficult to establish an effective doctor-patient relationship and get those histories. So I'm not faulting anybody other than to observe that that data, that information is not there.
Let me begin at the beginning. In January of 2002, when the first detainees began arriving, remember, the only thing you see on CNN when they talk about Gitmo is probably Camp X-Ray. One of the things that I instituted, and this is for the record, I instituted the requirement that a robust medical record be established for each detainee as they entered Camp X-Ray. As a matter of fact, the ICRC was there when we did this. And whatever happened to those records, I can't speak to that context. But each detainee had a thorough physical examination so we could determine, as a medical group, the kind of treatment that they required. And based on that initial assessment, some of the detainees did not go to X-ray, but I established a relatively intensive care unit at the American Naval Hospital for some of those detainees. And during my 18 months as JTF surgeon, I knew those records were continually maintained at a level at which I expected to be maintained in any other American service member. What happened after that is I have no knowledge of. But the records were initiated as each detainee arrived, whether it be initially at X-ray or at Camp Delta later, and a robust medical record was established for each detainee based on number. We didn't know them by name. We knew them at that point by number.
Well, thank you. I'll go just a quick comment, then I'll go to Dr. Nathanson. One of the issues that we see now, and that involves, and I believe that that's in fact, you set that in place, though, is that as physicians rotate, all that information is not available to the next rotation of physicians. Now, it varies because we've got really various kinds of populations there. We've had 850, I don't know how many first came in when you, about 8, and now we've got 164. So there's been a lot of change, but it is not available in a very accessible way as in terms of approaching your treatment. So next is Dr. Nathanson, and I think that as you've had the experience of with the hunger strikes, particularly as you think about this and that population, we'd like to hear what your ideas are.
Thank you. I just want to go back to something I said earlier in an intervention this morning, which is what is the role of doctors? And I think that the role of doctors is, and it absolutely picks up your point, patient-centered care, treating the patient, but it is also this issue of public health. And the public health argument is equally valuable because it takes us into areas where doctors are often working in areas where they're very uncomfortable. And it seems to me that if we talk of the military doctor in particular, they don't go to war zones to be prison doctors. They go to war zones to be trauma surgeons, to offer ordinary medical care to their own soldiers as well. And we've found that the doctors who then found themselves allotted to become a prison doctor for a period found it very uncomfortable. They found it was something they weren't trained for, that they didn't know what they were meant to do. So that actually is something that all the doctors around the table here will understand. We need to train them. We need to give them material and support in that role, which is atypical, where they have few skills and little knowledge and no experience. And that helps as well. And that training can also reinforce the fact of general ethics training, issues around autonomy and all the rest of it. But it can also reinforce this issue of the advice from, in the UK, it would be the Chief of the Defence Medical Services, that if they see something that they think is improper, they have a responsibility to stop it. And that is either to the local chain of command or through the medical chain of command. And we should be reinforcing that in the training. Could I just wave my little booklet that I gave you? We produced, after the Bahamousa murder of by the British Army of an Iraqi civilian, we produced a toolkit on ethical decision-making for military doctors. And this is sort of laminated every page, so it can go in your uniform pocket and doesn't matter, it won't get filthy. And that was with the Ministry of Defence approval. I mean, they asked us to do it. In fact, the judge doing the public inquiry into the murder of Bahamousa asked us to do this, and we willingly did that. And that actually explains in simple terms the sort of major issues that doctors are going to face in those circumstances. So it's not just the issue of prisons, it will include issues such as, treating civilian injured and so on, and triage and all of those things. So training doctors is important. But I think there is a question also about whistleblowing that I'd like to raise. So why didn't the doctors at Guantanamo say we shouldn't be force-feeding? Why didn't the doctors in other situations, the British doctors and others who saw people being abused in prisons in Iraq and Afghanistan say, this is not acceptable, this must stop? And we have to ask the question why they didn't protest. Is this culture, is it that they don't realise that it's their duty? Or did they just not bother to notice? And I think that that's an important issue. And we've got to address that. We've got to make them understand that it is their role to protest, but that also means we have a duty to protect them. And we know that the history of people who blow the whistle on abuse usually destroy their careers in doing so. And we have to create a situation where they are respected and revered for what they do and not penalised.
Well, could you expand a little bit on how long the training and preparation has, in your experience, taken, or what's worked?
The simple answer is that part of the training, the general training that all medics in the military get, in the same way that all medics working in prison medicine and so on get, is a general training which would cover the issues. The difficulty is what happens when somebody is sent out with relatively little notice, and that's been the key. And the evidence has been that they haven't had that the information that they've then been given is about the local situation that they're going to find. So it has not been upon the ethical issues around the duties they might undertake. Hence the book, because now we have an agreement from the Ministry of Defence in the United Kingdom, and everybody in the medical side, which is not just the doctors, it's the nurses, it's the corpsmen, it's all of these people, will get a copy of this book. They will be given access to particular websites which are designed with case studies to help them understand how to make decisions. And that is meant to be ongoing, because there is pretty good satellite communications and internet access in most parts of the world that we send our military to. So that's the way we do it, to pick up the fact that there often isn't time to go into the details of the individual circumstances they're going to meet.
There's a consulting group that they can go back to, an advisory group?
Well, the advisory group, there's no specific advisory group, but they're given contacts to contact the BMA, because I have an ethics advisory and discussion function. We take phone calls and emails all day, every day. The General Medical Council, which is our regulating body, will give help, but also, most importantly, the Medical Defence Command structure will give advice and support. And that's why it was absolutely essential that this is something that they support completely, and they do.
Next is Dr. Mark Sageman, psychiatrist, also sociologist, I think, who's had an interesting experience as both as a station chief in Afghanistan, was it? No?
Promoting me.
All right. But has advised both the CIA and the Department of State, and has been involved with these issues for some time. And I think you particularly, a couple issues that I know you're thinking about. One, I'd like to talk about what the role is of military medical people in this particular theater when it's set as another point of contact in asymmetrical warfare, and what the differences mean to be a military physician who's been in one combat theater in Afghanistan and now comes to this very different combat theater that's still, which is how it's characterized, rather than a correctional facility. And then what that means in terms of how you would accordingly be able to, in that different contact, advise other leaders about what these people are really like. I mean, to humanize them in a way other than just what is often the depersonalized characterization of them as an enemy. And then what you think of what might be a way to approach them and accomplish the kinds of things that we wish to accomplish as providers.
Thank you. I'm just amazed that you can draw a 1-minute conversation to 5-minute remarks that are much better than what I'm going to tell you. Let me start with some personal remarks and then make a general point about how we are as human beings and what solution we can have from it. I've always tried to understand situation. What is the meaning of what I'm doing? There's no doubt. Today, all the gentlemen and ladies that you heard told you that we had clear ethical violation in Guantanamo. But, how did it come about? And what can we do about it? So let me talk a little bit about myself and see how the experiences that I've had that are somewhat relevant to this. I'm a child of Holocaust survivors, which in a sense makes things a little bit easier for me because I always take this extreme situation as a kind of guide, a moral guide of perhaps what I do. Would I have been a Nazi physician, for instance? I don't know. I mean, I'd like to think not, but I don't really know. And that's kind of the truth. So how can I answer this question? My career has been to be a professional outside insider of everything I did. Whether it's my accent, I grew up in France, I spent a lot of time within U.S. government as an operator, not as a physician, and in a sense, as a lapsed physician among you right now. So I was a flight surgeon in the U.S. Navy. There I learned about dual agency. What we're dealing here is not dual agency. We're dealing with a prisoner of war camp. This is not a prison. This is not a correctional facility. Let's be frank. We are taking care of the so-called enemy. And this is really quite different. At the CIA, I was a case officer, and before I was promoted to chief of station, I actually did run the war against the Soviet in the 80s. But not as Mil Bearden, my boss, as a guy who actually had contact with the major Mujahideen commanders against the Soviets. There I actually learned not to use my medical knowledge. I was already a physician, I came across this guy who was coughing. He had just traveled from Mazar Sharif, 9 months on the road, and, he obviously had TB. So I said, I'm a physician after all. Do I have a duty to this guy? Yeah, I think I do. And, I happen to be on his side. So, I kind of wrestled up a year's worth of INH to give to him, and I did. And then, I heard months later that he died. And I said, how did it come about? I say, Doc, he thought that 1 pill a day is good, so why not all 300 at once? In a combat situation, you don't control the situation. And it's really hard to practice medicine. It should be practiced, even though I told the guy, what to do. But, that kind of cured me. Unfortunately, somebody died. Then I became a forensic psychiatrist as a consultant, not a correctional officer. So my job was to try to understand the subjectivity of the defendants in order to kind of, question mens rea type of issues, And then, I've been a physician the last few years. I've been a consultant Secret Service trying to protect the president, the NYPD. I'm not going to talk about that, even though I think it's overblown in the press. And as counterintelligence, counterterrorism advisor to the chief of staff of the Army. And in the last capacity, I went to Afghanistan. They called me up on the green and blue violence of last year, which was killing a lot of people. So I said, what can you do about it? And as part of it, I was part of this, little team that was kind of supporting my work to try to understand. And, by the way, I'm very proud that we've decreased the number from about 50 to about 10 this year, with a number of deaths from 67 down to 12. I mean, this is probably the best work I've ever done. But anyway, as part of the team, we're kind of keeping track of the guys who killed our guys, or killed coalition guys. We used to call them jackals. And each time, we found one and tried to bring him to justice. If he resisted, we killed him. And there was a celebration among the team. And, so I high-fived the others, said, guy, we just killed somebody. This is wrong. And this became a joke. Just kind of, so people kind of, each time they got another jackal, they high-five each other, and then they look at me and say, oh, this is wrong. And, and then they start laughing. This tells you something about human beings. And basically, what we all do, and this is natural. Now, I don't know if people read Daniel Kahneman's wonderful book, Thinking Fast and Slow, but cognitive science has really evolved tremendously in the last 30 years. And we know that we always naturally self-categorize. Whenever we are in the situation, we categorize ourselves, us, them, and that's very common. In a war situation, when the threat to the in-group is so high, we all become very emotionally involved and kind of develop this pressure of being part of the group. So the increased threat, increased pressure of being part of the group. Unfortunately, this social identity as part of that group, whether it's being an American attacked by Al-Qaeda or a military physician defending the country, trumps our identity as physician, our professional identity. And therein lies the real problem in this very issue we're talking about. And that's why, whether the Nuremberg trial tells us something, it is indeed that they considered themselves German before they considered themselves physician. They were human beings. I'm not condoning them. I'm just trying to understand them. And that's why Gitmo is not a correctional facility. Medical ethics have been generated in a situation where we're all members of the same group, whether it's a small city in ancient Greece or all part of the same society, and we all treat each other as human beings. But when you deal with the enemy, it's different. They now become an abstraction, they depersonalize, they dehumanize, just by the process of categorization. It has nothing to do with any training that you undergo or desensitization. This is the reality, unfortunately, of the situation. It's a normal process of self-categorization. So the pressure on a physician, military physicians, to be part of Team America. Stay in your lane, as somebody put it earlier today. It's inevitable, we have a huge amount of evidence in social psychology, experimental psychology to really show that, whether it's a prison Stanford experiment, which have been repeated in Britain to my surprise. And what you're really asking the physician is really to resist this tendency to be a good team member. This is really very difficult. So what can I recommend? Basically, what we're trying to ask them to do is to have their professional responsibility transcend a very strong polarizing context and treat everybody equally. This is difficult, especially as Steve just mentioned. A lot of physicians who actually go to Guantanamo before had a tour in Afghanistan and a tour in Iraq where they saw their friends die. This does not allow you to have much empathy for the guy that you're going to face in a prison. People mention independence, autonomy. I wish we could have it. I'm a little pessimistic towards it. And the problem is that once you're a member of a group, all your frame, all your assumptions about this group are hidden. You don't really know that you even have them. So, the various, mention were really kind of small technical details without looking at the overall situation. And a focus on the small medical details often obscures the situation that you have. And if you're trying to understand people from their own point of view, this is kind of almost empathy. Empathy is, is viewed as a betrayal by the group. Empathy for the other guy. That means you're not part of a group, you're empathetic to the other group, you're betraying us. And this is where the divided loyalty comes in. You're asking those guys to have divided loyalty. I'm not sure it's possible. In terms of the assumption, hidden assumptions, like the battlefield tactics that you mentioned, that's typical. Now, the other problem is that any kind of intervention in that type of setting could also be detrimental to the patient, like the increased scrutiny, the increased search, the lack of privacy. It would drive me to suicide. You kind of have to understand how you look at the situation. It may be a humane response to this horrible situation that those people are put in. Throughout the last 2 centuries, I'm just finishing a book looking at terrorism all over the world. The use of suicide in political prisoners to call attention to their horrible condition as prisoners has been very common. And indeed, when the government changes, those guys now become martyrs. They're being celebrated. They're not crazy. In that sense. And that's what we have to understand. And that brings back to this notion of milieu that you raised, Steve. When you said milieu, it immediately reminded me of, a British psychiatrist, R.D. Laing, who was kind of, stretched the point a little bit too much, I think, saying that symptoms of illness are probably reaction to a perverse situation. It is true in some cases, and I think it is true in this case. It is not true in most cases. I went through psychiatric training, and some people did suffer from mental disorders. I don't think they're fictions, but anyway, in this case, I think it may be apt. So what is the solution? Well, the solution is very simple. You need the person, the physician, and I'm trying to bring the physician back into the situation, into the discussion. You have to have him as a neutral member, not a member to either group, either belligerent group. I don't think it's possible to have a member of a belligerent group transcend his group, wipe everything out and be neutral in this situation. And it's not fair. And actually, we do have models like that. The ICRC is exactly that. It's they're not party to either belligerent group. Médecins Sans Frontières, the same thing. So in terms of the military, the use of military physician, it's the worst possible solution. They are not only part of a national team, they're part of the team that actually, does the dirty work, that defends a large society. It definitely is the most convenient solution, but it's also the worst of all possible solutions to use military physician. You put them in a horrible situation. They have their own in-group, namely the military, and if they can show sympathy or even empathy, forget about sympathy, but just trying to understand the enemy, they're seen as traitors now. And that happens to me all the time. People say, whose side are you on? And that's kind of the first question that I ask. So what I would argue is really, to ever be neutral. Now, I am so glad to see so many people who are still part of the in-group being able to transcend it. But this is really too much to ask from a regular physician. I don't really think that training is the solution. No matter how much training you're going to have, you're still going to be moved by whatever you see in the field and take that with you when you are confronting the so-called enemy. And by the way, this is a label we put on them. Some of them are true enemy, many of them are not. But it doesn't really matter. That's what you see. So, how can you build trust with your enemy? I would put it to you, that's impossible. So the trust needs some kind of neutrality. Otherwise, it's just like treating animals. You just do a lot of testing, but you don't really talk to them. You don't try to understand the subjectivity. So my point is, let's try to have a neutral medical corps. I understand that neutral medical corps made of foreigners would be an impossible situation. It is a non-starter. So perhaps a neutral medical corps of perhaps cleared physician, because there's also now the potential that the enemy can talk, and so you see, this is kind of the perfect storm for medical ethics. It's almost an impossible situation. So a neutral medical corps, perhaps trained civilians who actually can now identify with other civilian physicians like themselves, who can now treat other people and may give confidentiality, build up trust, and so on. That's all I have to say. I hope I answered some of your questions.
No, I think that was excellent. And I think you've given us, as we open it up, a couple items for us to consider here in terms of just how we both conceptualize the facility, characterize the detainees, and then what would constitute operationally neutrality for a medical team that's going to support them. So I really do appreciate and I'm glad you've been able to attend. Our next panelist is Dr. Vivian Hood, who is former president of the American College of Physicians and also chair of their ethics committee, and a nephrologist, and we look forward to hearing your observations, comments of today's meeting.
Thank you very much. Good afternoon, everyone. And I, too, am very honored to be here among this incredibly distinguished group and discussing this really important topic. In terms of disclosures, I really have no credentials to be giving comments as compared with my colleagues, except that I am a nephrologist who's taken care of people who've been in prison, as most of us who are in medicine have done. But I do have a few thoughts about what I've heard today, and I've learnt already so much. My first thought is that this is really not an ethical issue. it's a problem that we've been hearing about, and I believe that we can take some lessons from ethics to help us find solutions to the problem. But it's really a problem about bad care. And I say it's not an ethical issue in total respect to my colleague here, because really I think we all know from our professional obligations as physicians, whether we're in the military or in civilian life, that our ethical obligation is to provide patient-centered care to those who need it when we can. And that means whether they're citizens or not citizens, whether they're here illegally or illegally, whether they're in prison or out of prison, whether they're in a war situation as prisoners or combatants or enemy combatants. I've never been quite sure about the distinction between these, but that, that is our ethical obligation. And I think we have plenty of evidence in terms of our duty to care to accept that. The issue is how to fulfill that in these challenging situations. And so when I look back at the idea that what we've been hearing about is really a problem of bad care, I'm thinking about why doesn't a patient get good care? And I'm talking here about a detainee. And there are sort of very many levels of it that we've heard very well described here. The first one is that the patient may refuse the care, and that from an ethical point of view, this is all right if they have given consent, preferably informed consent or always informed consent, and if it's in a situation where they've been shown respect and dignity and there's some trust, none of which usually occurs in some of the situations we've heard about, but that's still something that has been well described. And what, in terms of solutions, perhaps what Dr. Scott Allen mentioned this morning is sometimes we can find out what the cause of the refusal is by looking very closely at how things were done. The second issue is that maybe, I'll just describe them quickly, a lack of physician input. They didn't give the right advice, the lack of facilities to deliver the advice, or some kind of non-physician decision-making that overrides that advice. So let me just look at those very briefly from what we've been hearing about this morning and this afternoon. Firstly, lack of facilities. There's clearly been lack of facilities in this detention center at Guantanamo. How do we improve that? We simply have to work hard with the military to make them get the right facilities to deliver the right kind of patient care that they have agreed to deliver. And maybe, although it's not very perfect, even use the model of what prisoners get in the US in the same setting, at least in terms of the facilities to get the care. But what about the physician role? The physician role is what I guess I know most about and what we've heard most about, and where we all feel our ethical principles should be able to guide us. What about that role? And what we obviously have to help physicians with is knowledge, but knowledge doesn't allow people to actually change or deliver change. They also need capacity. So in terms of knowledge, I don't think we've done as good a job as we can in ensuring that all our physicians, and especially our trainees, know ethical principles and the principles of professionalism. And we have to start delivering this at the beginning of medical school, all the way through medical school, during residency, and it has to be one of the competencies on which we judge our trainees as they leave and go into the world. And some of that should include understanding of military obligations, the medicine that's practiced in the military, practiced in prisons, as well, and how that can challenge what's going to be their ethical responsibilities, even if they only come in contact with one or two prisoners during their profession. But we really have to work very hard on that. We have to support them, as has been mentioned very much, in not blaming them for not always being able to do what they believe is the right thing, because I think physicians do want to do the right thing. Some of the time they just need more help and recognition that they are. And also we need to give them, as I said, some capacity to do that. And maybe it's checklists. Maybe it's these toolkits that we just heard about. People are very good when they're actually given help to do what they know is the right thing. We also need to give them some other tools. Like I thought today, this concept that force feeding is equivalent to torture, that this is well defined in many documents in the world, even if it's not here in the United States, perhaps it should be, and that if we can give people, physicians, that kind of information, this really helps them not participate in practices that are not ethical and are certainly inhumane. And then there is the larger issue that I think we've heard about today, and that is of non-physician decision-making and how that has its implications in the delivery of bad care. This is a really important issue from our discussion here. But it's important, and the two solutions, or one of the solutions that came out discussing this issue was this idea that physicians and other healthcare professionals must have independence from any other group that can override their decisions. In the military, it's pretty straightforward, but this kind of thing is also happening in civilian life at a much lesser consequence than here, but with different kind of organizations, institutions, insurers, political bodies, states, which are telling physicians what they can and cannot do in terms of delivering care. So it reminds me that this really is a much bigger issue, as Dr. Thompson said right at the beginning of today, a much bigger issue than just what happens at Guantanamo. So this non-physician decision-making. So we need to promote our independence. We need to, from the chains, from these other groups, and support our colleagues as they stand up to that. We need to leverage our value to bring about change in systems, as Dr. Allen mentioned to us. I thought that was a particularly important issue, but also, as Dr. Wolf really illustrated for us, that if we can get together as a group, we can change laws in a country or in an area, and that is our obligation as physicians, and not just as single physicians, but as physician organizations. So I was particularly pleased to hear Dr. Lazarus and the AMA being so supportive of trying to bring about these changes, and I know the ACP and its ethics manuals and previous letters has done the same thing about issues such as torture, speaking out against that and the obligation of physicians not to participate in it. And there's just one final thing that I want to say about this issue of it's not just non-physician decision-making, but it's what this whole topic is saying about our system, that this system is destroying more than the health care of the individual detainees, as we have clearly seen. It's destroying our reputation in the world. Again, Dr. Wolf pointed this out. This is not a good enough reason by itself, but it is of concern. The US has always been looked to as a country that has the best science, the best medical care, and pursues good values for both individuals and groups, even though we don't always deliver on that. That's how we are seen, and these kind of practices really bring that into question, and bring out the issue about it's not just how we want to be seen, but who we are. I think this came out in a statement from the president about the hunger strikers saying about the force feeding, is this who we are? Is this how we want to be seen? Is this who we want to be as individuals, as physicians? Because it's not all about the health care of the detainees, it's about who we are in terms of delivering care, whether or not these people are good or bad or threatening to us. We have to do it in a safe manner for those delivering the care, but also to fulfill our own sense of who we are. And it's not just who we are as physicians, it's who the other people are who are participating in the care of these patients, these detainees, the guards, the other people. What does it do to people to treat other people in a dehumanizing way, to treat them as, in quotes, animals, as you said, because they are in a war situation? We have seen this happen in our country, in other circumstances, and we know that that is as destructive to the perpetrator as it is to the people who are receiving the bad treatment. And we have to remember that that's the kind of system that we are encouraging if we don't put a stop to it. So I would say for all these reasons, we really have to put a lot of pressure at all elements to change some of these practices that the military believe are in the best interests of the country, but really are not. And that may have to be through a political route. I hesitate to even mention that word, as that's not very effective at the moment, but we have to keep trying. That we have to change ourselves and how we think about these things and support our colleagues so that they can continue to do what they know is in the best interests of patients, and as so many people have already said, put the patients in the center. Thank you.
Well, thank you so much. Very eloquent, powerful remarks. And perhaps as we talk as a larger group, the basis of an action plan or campaign plan, which would take the kind of considerations that you've put in play here, I think they're very important as we go forward. Really appreciate your participation. Our next speaker is Dr. Joseph Fins from Cornell, professor of medicine, also chair of, I think, ethics panel or committee there, and someone who's been very involved with this issue, both at its medical school and the American College of Physicians. So thank you, Joe.
Well, I just want to thank you all for the opportunity to be here, and I was just reflecting on what Virginia said, and I had the opportunity to serve as her vice chair of the ethics committee during our time together at the ACP, and you know, medicine is a civilizing force, you know, through history, and to think that we're destined to go back to tribal warfare, and that medicine and our super egos can't somehow exert themselves to overcome the primal urge to see the other as destructive and evil and always different. I mean, that would be an indictment of civilization. So I'm going to vote for civilization, and I'm going to put my nickel on the fact that we're going to try to make a difference by having booklets, by doing all these futile things, and hopefully we'll win the game. I think about being here today, and I'm just so honored to be here. It makes me think about my dad, who was a World War II combat medic. He was at Utah Beach, D-Day plus 14 or so. He was in combat. I told him he's going to be 90 in 3 weeks. He was a staff sergeant. He'd be amazed I'm sitting next to you. You know, it's like a real upgrade, pay grade. You know, I asked him, I said, how did you guys treat prisoners, you know, when you were in combat? He said, well, you know, when you're in combat, and I think this gets back to some of the comments about definitions, when you're in combat and you're going after a wounded soldier from the other side who's just killed one of your friends, you know, you do rough him up a little bit when you put him on the gurney. But then once he's secured, he's a prisoner, and you treat him like a patient. And there's a transition moment, but they were able to overcome it. And I think by the notion of this historical resonance and how different it seems to be today versus it was years ago, was struck home to me by this wonderful little book. I don't know if you know this book. It's called Stark Decency, and it's a book by the University Press of New England. It was written in 1988 by a guy named, I wrote it down here somewhere, Nell or something. I'll get it for you. And basically what it was a commemoration. I'm sorry, Alan V. Coop was his name. It was a commemoration of the 40th anniversary of German POWs coming back to a little town in New Hampshire where they had gone during the war. And it was the 40th anniversary. They worked in the forest. They worked in sawing wood and chopping down trees. They were so integrated into the community in this little New England town that they developed relationships and affections with their jailkeepers, in a sense. And they came back to celebrate their time together. And the place was called Camp Stark, ironically, and the title of the book is Stark Decency. So maybe we should aspire to a little stark decency. Now, in the spirit of trying to kind of cobble together, and a baseball fan that I am, and figuring that if I hit 300 on what I'm going to suggest, I will have done well for the season, I'm going to give you a list of ideas that I've just kind of assembled today based on what you all have said. And I've broken it up into preparation and prevention. Some of this we've heard before, cultural versus structural reforms, systemic protections, societal outreach, and the role of organized medicine. And this is supposed to work. Okay. So I think the first question that comes to my mind is about the doctors. And where's the breach in the circuit? Was it a lack of individual discernment? Were they co-opted by the context that they were in? And I think we need to, have data on service members. We need to stop guessing about why they did or didn't do what they did, and have a kind of a debriefing that through a quality assurance process that would have some kind of, immunization and privileging so that we could understand what the motivation forces were. Was it affinity with the group? Was it a lack of education? So we can tailor our interventions in a constructive way. Regardless of that, I think education of doctors and flag officers and medical ethics should be undertaken. I would just add that I think it should be done not only in the academies and in USIS, but with civilian expertise as well, because I think the mixing of perspectives would be very constructive in dialogue. And this is ultimately to foster the independence that doctors need to have to be a patient advocate and to encourage professional autonomy, and even taking the risk of being a whistleblower every once in a while if that's necessary. I've also become convinced, because of the earlier presentations, that doctors who are deployed to settings like this should have some kind of exposure to correctional medicine as a prerequisite for their deployment, and they can't be deployed to these places until they've had their educational experiences as a kind of certification. The second question is, cultural versus structural reforms. Are these things changes that can overcome, this separate world that Dr. Grodin suggested is a separate world? Can we put in cultural change agents as, we've all seen transformation of death and dying in America in the last 15 or 20 years through an investment in cultural change agents. And I also think we need to incorporate structures that reassert normative practices that exist in the civilian world. You're the only doc, you're all by yourself, you're on an island, you can't go on that subway, you're just sequestered, and you're sort of divorced from all the forces that keep you civilized. Is there a role for a medical ethics committee to be operative in places of a certain size, to flatten hierarchies so that people can speak honestly? Hard to speak honestly and flatten hierarchies in a medical context, necessary for military life. But we have the same thing when you're chair of an ethics committee versus you're the attending on a floor. Your roles change and how people interact with you change. And that might be important to bring in the civilizing force of an ethics committee, in part or whole, from the whole hospital, the home hospital that supervises the outpost, or something even intrinsic to the camp that you're in. I think there needs to be a mechanism to accept conscientious objection within the military context. People should have an opportunity to have a hearing. Some of the most perplexing cases that I've been involved with in my own institution have often, sometimes we get overruled by the authority, and conscientious objection sometimes becomes the mechanism that tilts the weights in the favor of a different decision. I think when you have things like suicides and deaths, there should be a standard sentinel event mechanism and a near miss mechanism so that these things are reviewed, maybe not directly there, but at the one step removed, and all the data is collected. And JACO has standards for this. Anybody who's been through a JACO review knows what this is. Also, I was struck by the deluge of pharmacopoeia that our patients were exposed to in the redacted medical records, and also read that even our service members are sometimes over-medicated as a means of control as well, and to heighten their ability to act in stress situations. So I think one thing that we should also think about is having a systematic formulary review to look at practice patterns both for detainees and for service members and establish standards and practice norms. At a societal level, I think we have to fundamentally reassert civilian control over the military and affirm it through this licensure process. I think this is something we did in New York State. We can look at the Office of Professional Medical Conduct, and Dr. Thompson was a leading proponent of this, and I got to carry the ball for him for a little bit, but we didn't make it to the goal line. So I've got a baseball and a football metaphor, and I apologize, it's just too much. But one of the ideas here was that people who were deployed overseas could reach out to their Office of Professional Medical Conduct or their state licensing boards, not to be sanctioned, but to report a situation that was uncomfortable for them. And that would, in a sense, say, I have to do this, my license is at stake, I am licensed by my state, and I'm obliged to do this. And this could help insulate these folks from having to do things that they don't want to do, since healthcare is regulated at the state level and not at the federal level. And I too would be against a federal license. This was meant to be a picture of the legislation that Assemblyman Chairman Gottfried had introduced, that Dr. Thompson and New York ACP helped to draft, but it's not coming out. My penultimate slide here is what the ACP Ethics Manual asserted in its 6th edition under Virginia's leadership, and it was published in the Annals of Internal Medicine in 2012. This is not the exact language, but just a kind of excerptation. But physicians must not, pretty close, must not be a party to and must speak out against torture or other abuses of human rights. Participation by physicians in the execution of prisoners except a certified death is unethical. And physicians must not conduct, participate in, monitor, or be present at the interrogations or participate in developing interrogation strategies or techniques. And a physician who becomes aware of abusive or coercive practices has this duty to report to proper authorities and advocate for necessary medical care. Exploiting, sharing, or using information that you get as a doctor for interrogation purposes is unethical. So we're very proud of that, and we're proud to join the APA and other organizations in asserting that. And my final point is echoing what was said earlier about medical education. We need to go after the younger doctors because sadly they will fight the inevitable next war. And I think we should involve the USLME, the Federation of State Medical Boards, the AAMC, and the ACGME, all the accrediting organizations, and make sure that this information is part of the curriculum in medical school and residency training, but it's on the exams. Because everything in the curriculum now is teaching to the exam, and you don't exist in the curriculum if you don't reside in an exam. So those are my few points, and again, thank you for the opportunity to be here.
Well, those are great. Thank you so much, Joe, and I like the idea of teaching for the exam, something we understand in the military. Our last panelist, and fittingly, is General retired Ronald Blank, who's had a number of very important positions, and through his experience and even his current roles at the Uniformed Services University of Health Sciences, has been exposed to many of the issues that we're talking about. The USIS does run a training, pre-deployment training for the doctors. There's an ethics course there. And of course, as a Surgeon General, he understands, and a career Army physician, the very complicated role that military physicians have, particularly when it comes to their performance of duty and relationships with the line command. So, General Blank.
Thank you for the opportunity to be here, and Steve in particular for the thank you for the opportunity to be here, and also to press the button and to have me participate in this group. And Steve, a particular thanks to you for seeing that I get the invitation. Well, first, I'd like to say that I am very privileged to sit next to two other internists, so that at least there's three of us, and while we may not outnumber the psychiatrists, there is a bit of strength here, and so we'll outweigh them a little bit. I come at this from the perspective as a military physician, which I've been for 45 years, 32 years of which was in uniform. I've served in combat. I've taken care of our own soldiers and also the enemy. And I think that goes on today, and there's certainly many, many experiences that we've all heard about of the care that is provided to the enemy was in Iraq and now in Afghanistan. That is far more problematic in Guantanamo. But I think the example you gave of your father still is true today. We try to do the right thing, and military physicians, whether they're in combat here in the States or even in Guantanamo, try to do the right things, try to behave ethically. But there are significant issues that clearly have been brought up here that interfere with that ability, certainly in the case of Gitmo. So I, in taking notes during this very, very interesting discussion, pose 6 or 7 questions that may give us a way forward as we then come up with recommendations. Fundamental question is, how do medics, how do military physicians and other healthcare providers convince the command to accommodate to medical needs and not do things that are against medical needs? Do we go locally? Do we go through levels of command? Do we go through whatever it is that we can identify? We need to do that and figure out where the pressure points are and try to get that point across. What guidance is it that we give to physicians? And we've talked about that a lot. I'm not going to belabor it, but yes, it's training. Yes, it's a manual. Yes, it's all of those sorts of things that need to be done and done much better. And there may be specific training, in fact, I'm convinced there is, for not just military physicians who go in and will take care of enemy combatants, but also that specifically go to Guantanamo because of the politically charged nature of that whole thing and the distinctness of the commands and the visibility and so forth and so on. So we need to provide these folks with that kind of information. Absolutely correct. Should the command's medical and the prison administration be better firewalled? Probably so. I know that at least Al has told me, the medical facility there actually goes up to Portsmouth with, I'm not sure what the command responsibility is to Southern Command, which oversees the prison administration. How can we make that more distinct, more separate, so that physicians who, by the way, getting to the point that, well, they're in that culture and they kind of identify with the line group, these physicians are not like a battalion surgeon. I was a battalion surgeon in Vietnam, and believe me when I tell you, I identified with my battalion because they protected me and I gave them care, and I was part of that little band. Well, it was a big band actually, and I mean that was something that was very, very tight. It's not that way here, at least to the best of my knowledge. Medical folks are there, prison folks are there, so we need to not emphasize exactly, but make sure that that distinction is known and appreciated. And I think somebody had used the term, a couple of people, stay in your lane, absolutely correct, but fostering that distinctiveness to the extent that you don't get involved with the culturalization with the other group. And that brings me to really something that I've thought about and didn't hear mentioned here. Should DOD send to the island, not just back here in the States, an ombudsman, an IG, somebody who is totally independent from both the medical and the line commands, who reports to, I don't know, the Secretary of Defense for Health Affairs or Assistant Secretary of Defense or somebody, Deputy Secretary, who would be responsible for overseeing what goes on, not in a command sense, but there to hear any issues of, what was the term used, of whistleblowing, issues that somebody is concerned about but isn't getting what they consider to be the right hearing at their command level or some other level. Should there be someone in that position, it's something like the attorneys we've heard about who are independent, but they represent detainees, so it's not like that. It's a very, very independent person, however. Getting to the issue, should there, I actually toyed with the idea of, on all the phones you have a 1-800 number to report something or other. Maybe we ought to have a 1-800 number or a hotline of some, and I say that only semi-facetiously, but there must be some kind of a mechanism, it seems to me, other than the usual channels that we could foster or recommend. Something that came up when we were talking about outsourcing the medical care and just, hey, taking it out of the military entirely. I've been part of the military a long time. I will tell you that isn't going to happen to an extent. But here's something to really think about. We've been using public health service officers in the military. They have teams they've given us to provide care for patients with PTSD, et cetera. They're all over the place. Why not think about at least asking the Public Health Service, a very different organization. They don't answer to DOD, by the way. They're in Health and Human Services, to provide medical care practitioners instead of having the military or adding to the military, being the ones that are the face to the detainees and so forth and so on. There's a variety of ways you could structure that. So it's an idea perhaps worth considering. As far as continuity of care, can't we do that better? There's certainly ways where we could rotate the same physicians for certain specialty care over the course of, this is an island 90 miles away. Why not fly somebody from Eisenhower Army Medical Center, which General Xenakis used to command, or the Navy, there once a month to attend to their endocrinologic or whatever needs. Now, if you need it more frequently than that, then you either have to be on site or for psychiatry, and I don't know how well it would work culturally. Telemedicine has, against my prediction, which it would never work in psychiatry, telemedicine is absolutely extremely successful in psychiatry, and that's something that I don't know if they use there or if it would be possible to provide that continuity of care. Now, obviously, it's just individual care. You can't do group with that very, very well. I listened intently to the discussions on the ethics of involuntary force feeding, and certainly there's many, many reasons why that is considered by many unethical. It's not considered by all to be that, however, and we need to make sure that we have room for a discussion with those who believe it would be unethical not to do that. They're probably fewer in number, but I'll tell you, I spoke to one in the military who is fervent and has written about it and believes that's exactly the right thing to do. Agree with it or not, we need to be sure to listen to those people and not dismiss them out of hand. And then lastly, it's interesting. When I was Surgeon General, I was asked on at least 2 occasions to authorize physicians to participate in executions. Even though we weren't executing anybody, they just wanted them to stand by. And I said no. And I said, not only that, but you can't use anybody in my command to do that. So it's not just physicians we're talking about. Let's be very, very clear that we as physicians have the responsibility for care of patients, and we can't say, well, we wouldn't do it, but if a physician's assistant does it, it's okay. No, it's not. that is absolutely a cop-out. We need to take that into consideration as well when we talk about the non-medical care issues. And with that, again, thank you for allowing me to participate.
Well, thank you. That's very valuable. I like particularly the conversation which does look at the suggestion of the involvement of a public health service, officers, physicians, which I had also noted as an option, because I share your aversion to contracting out in the way that we do that. But to have someone non-military, even though they wear a uniform, have a different kind of issue, be responsible for this facility, as long as it's going to be there, is, I think, an option that we can discuss here. Add to that, though, before I open it up, is we do need to think about the demographics of this population and the implications for the authorization to sustain both the base as a detention facility and the hospital. We now have the youngest detainees are in their early to mid-30s. We have a number in their 60s. I'd heard that, I've not been able to get I thought there was a couple who were 70. They're developing chronic diseases. Many of them have had chronic diseases. And so the actuality of the burden of health care is going to be considerable. There is a mobile cath lab. It is not, I walked into it about a month ago. It is not operational. It doesn't have a cardiac cath tech. It requires a cardiologist to go down there. There are plans to move an MRI from Afghanistan to there. That will probably take at least a year. The internet access right now, they transmit images from radiology to the States. Internet access is intermittent, so that's been slow. I mean, the idea of using telemedicine is discussed. So there are some real challenges when it comes to understanding what the requirements are going to be for health care. So with that, I'd like to open it up. Jeff.
So I'd just like to say a couple things about medical autonomy. And although it's limited how to analogize this with corrections, you still can do. I appreciate Dr. Sageman's remarks. However, in correctional medicine, there's all different models of care. The employees can work directly for the warden, work directly for the state. In many systems, it's the equivalent of the Department of Mental Health provides the mental health services. Many systems have for-profit companies providing it, and a lot of systems now have universities providing the health care, and most systems have a mixture of all of that. What you lose when you're not working directly for the prison system, particularly when you're talking about a military system where you have guards, is where the biggest change comes from is your impact on the system. And when you're not working for the system, you have much less chance to impact the milieu or the practices. And you're seen as a total outsider, and that's the advantage and that's the disadvantage. And so, in a way, I'm glad, the public health service may be a nice compromise, but you really want to be able to impact the people who have the most contact and most influence on the prisoners are the guards. And if you can't develop a relationship with the guards to influence their behavior, you're not going to be able to do much.
But you see, that's an interesting, I mean, you might want to talk a little bit, educate us some, because, of course, not only are the physicians many military physicians, or few military physicians, have experience in correctional medicine. The MPs who are down there, who are the guards, do not come with experience from correctional facilities. I mean, they're not like the same correctional officers that we see in our prisons, and that's part of, I think, what
Well,
you're also
you also
saying.
mentioned training and how long training is. If you want to be an officer in a prison, most systems, you got to go 4 to 6 weeks of cadet school before you step foot into the prison. And a lot of systems, if you're going to be healthcare, you got to do the same. The problem with that is then you got to sort of unlearn some of the things that they've been taught. But I mean, that's the kind of basic training people get for corrections.
Other, Steve.
I think that today we danced around the issue of accountability. I'd like to put the accountability issue at least on the table. We've talked about education, we've talked about codes, but I think clearly our goal here is prevention. But I don't think we're going to get to prevention unless there is a transmission between education and codes. And that transmission is called accountability. Now, in other countries, they've handled this many ways: truth commissions, censure, and then when you get to sanctions, you got suspensions, license revocations, criminal sanctions, and so forth. But at the very beginning, you have to begin with truth. And I read, for example, from a UN Economic and Social Council. Health professionals at Guantanamo Bay have systematically violated widely accepted ethical standards set out in UN principles and the Declaration of Tokyo, blah, blah, blah. Alleged violations include being present during or engaging in non-consensual treatment, including drugging and force feeding. In some, reports indicate that some health professionals have been complicit in abusive treatment of detainees detrimental to their health. Such unethical conduct violates the detainees' right to health, as well as the duties of health professionals. That level of candor we have not seen from our major institutions of medicine. Instead, we've seen expressions of concern and reiteration of codes of conduct. Now, Dr. Sageman, I've read some of your stuff, and I would never want to debate you, so I'm not going to. And I agree with you that in some ways medical ethics in the military is the perfect storm. But on the other hand, I think that military ethics has always been using the horrors of the last war to ameliorate the horrors of the next one. That was true in the Geneva Convention of 1925, which addressed the issue of chemical weapons. It was true in Geneva of 49, which addressed the abuse of prisoners during World War II. It was true in the many treaties that pertain to the issues of nuclear weapons. And indeed, in some ways, it represents medicine's high point in the Nobel Peace Prize that went to international physicians for the prevention of nuclear war in 1985. And I fear that our reluctance to lead forthrightly by at least stating the truth within our own house of medicine actually sets the stage to allow the continued rot within medicine, which goes from not acknowledging the truth of what happened to continue to do damage to the stature of medicine. And we need to at least go that far even if we're not willing to go to sanctioning individual professionals in whatever rank they served, which includes people going up to at least the level of general.
Okay, thank you. I'm not sure. I have to defer to those of you who have more involvement in the professional associations of what might be, I guess, options in terms of that kind of more transparent statement, I guess. and analysis of what's happened. And don't know if, I don't want to put anybody on the spot, but I will. Dr. Lazarus or Dr. Hood or somebody.
Well, I think as I said before, I would not be aware of what kind of sanctions may have occurred or what kind of investigations may have occurred either through the CJA, Council on Ethical and Judicial Affairs, or through the state licensing boards. I'm just not aware of how many, if any, have happened at the state level, and if those had then been reported to the AMA CJA, what action they had taken. So I'll have to defer, and I just don't know what's occurred. It'd have to be at the state level.
Well, setting aside the question of individual sanctions, let me simply propose that since Abu Ghraib revealed the issue of medical complicity with these human rights abuses, JAMA, for example, which I recognize is different from AMA, has not editorialized once with any statement remotely comparable to the UN Economic and Social Council statement that I read from, nor has it commented editorially in support or disagreement with similar statements by the ICRC. They've taken a position of, well, we'll just say that we passed the Declaration of Tokyo and that's it. I don't think that that's sufficient for the level of problem that we now have today. But again, I think that the issue of sanctioning individual professions is different from the question of truth, which is fundamental.
Yes. Yeah. Douglas.
If I can just say what happens in the UK, which is considerably different to the US because we have a single state licensing authority, the General Medical Council, and a single medical association, the BMA. So things are a little different, although given that 3 parts of the United Kingdom are trying to get independence, we may end up as a federated structure of only 4 parts immediately, and that would happen within the next 2 years. But anyway, we know that there's only been 1 trial of a doctor so far. We know there are a number of others pending. All of those cases at the medical board, at the General Medical Council, are waiting until the criminal trials are over, and there's a series of those underway at the moment. And the General Medical Council will have said that they will pursue these cases, but not until they've heard the outcomes of the criminal trials. And that makes sense because it makes it easier for them to find against individuals if the criminal case has been found. We have spent quite a lot of time over the last few years defending doctors who have refused to follow orders which they consider to be illegal. And we have reported doctors to the General Medical Council and to the Director of Public Prosecutions in cases where they have followed orders which we believe to be illegal or unethical. Depends the nature of the order on who you refer them to. My favourite defence of a doctor was a doctor who was a prison medical officer who was seeing patients with a series of patients all with the same type of injuries. This was at a prison called Barlinnie, which is in Glasgow. A very, very rough prison in UK standards. And the prison management system decided that there was no case to answer and they weren't going to investigate. We held an impromptu press conference in the courtyard of the prison and managed to get out of there before the police arrived to arrest the BMA people. It hit all the national news, and I'm glad to say that the outcome after a little while is that the doctor is still employed in the prison service, not at Bar El, but at another prison where he's been promoted, and the prison guards who were involved in abusing prisoners are now serving long prison sentences. But there are risks, and there are risks to the organisation. The organisation that does the most to defend doctors who refuse to carry out illegal and unethical practice is probably the Turkish Medical Association, where this is routine. And their doctors are constantly, their senior officers, constantly faced with the risk of imprisonment themselves for defending their colleagues. And I think that's important. It is a very worrying circumstance. I was in India recently, where the Indian doctors working in the corrections facilities there said that they face 2 problems. If they don't assist the torturers, they themselves become the victims of the guards, and if they do assist them, they become the victims of the inmates. And the Medical Association does nothing to support them. And that was told to me in public at a meeting organised by the Indian Medical Association. So I think many of our institutions don't do as much as we sometimes could, and maybe Jerry, one of the things that we should do is go back to the World Medical Association as well and say, let's actually produce some absolutely practical guidelines which we will then expect every medical association to follow when we find these kinds of cases, and really, make it action-centred.
I might just make a comment about the ACP. We don't have any jurisdiction over licensing either. Anybody who wants to put a complaint against a member can send it confidentially and it will go to the Ethics Committee. If it's found to be valid, then there would be some sanctions, and one of them may be dismissal as a member or a fellow, and that would then be made public. So, but we don't have any capacity to go out and look for egregious behaviour, so it's all based on somebody making a complaint. But everything is very thoroughly looked at and very confidential. But I don't know if there's been any complaints along these lines. When I was on the Ethics Committee, I know that nothing certainly was made public that related to any of these issues.
Hans and then Bob.
Yeah. I wanted to make a comment for Mark Sageman. Just to come back to the point of the independence, and I disagree with the description of the problem, but agree completely with the solution which you proposed. I think also in military, dual loyalty is an important issue if you deal with the enemy. But nevertheless, the solution to have doctors who are neutral, who are independent, I think this is the way. And I want just to stress one point we didn't talk a lot about is the communication between the partners. And independence is crucial so the doctor has to be independent to be a valid partner on the same level for the prison administration or the military commander, for example. And if he is subordinated somehow, I think there is a problem. And my experience is, as I'm completely independent from the prison governor, he respects me, and he will never try to give me an order, and I will never try to give him an order about security issues. And so in this point of view, what the proposal of Mr. Blanc was, he's not hearing now, Ronald, I think to put a third partner in the system, for example, a neutral third public health agency who oversees the two partners, military doctors and the patient. I think this is maybe there are some risks to make the system more rigid. I think it is important that the doctor who cares really for the patient has a continuity, is a partner who is independent, and he can really implement ethical standards, which were standards in the country. So I think the independence should be done somehow, and maybe medical or army doctors should not care anymore for these patients imprisoned in Guantanamo. It should be a public, at least a public agency, independent from military. I think this is better than to implement a third partner into it.
Well, I'll have Dr. Lawrence and then Dr. Blank add to that. So because he can understand a little bit of he understands the command on the ground, and then also how it reflects up, and then Dr. Sageman. So,
just a couple of quick points. The 1989 team that investigated apartheid impact on child health in South Africa, a investigation sponsored by the IOM, PHR, ACP, and the APA, led to several of us on that investigation team being invited back to testify before the TRC on the health sector. And I just want to support Steve's notion that that would be one way to go. It seems in this current environment and the current attitudes of our politicians, highly unlikely that we would ever have a Truth and Reconciliation Commission, but the value of that in South Africa and Chile and elsewhere has certainly been amply proven. I'm struck by something that we started off this morning with a case that had to do with the fact that a prisoner's right to habeas corpus was being denied by inability to meet with counsel and to discuss the strategy around his case. But we haven't heard anything more about habeas corpus all day. And I want to come back to the fact that one of the premises of international human rights law is the interdependence of all human rights, and the fact that we in the medical profession have an obligation to help fulfill the right to health, and yet we can't turn a blind eye to a gross violation of a civil and political right that basically undermines the entire premise of fulfilling the right to health. And I'm just curious why nobody has felt that it was worthy of commentary about that, because it seems to me it's at the heart of the case. We have a fundamentally flawed system in place in Guantanamo. It's a gross violation of civil and political rights. It's a gross violation of the Geneva Conventions. And without fixing that, everything else seems to me to be very much around the margins. And then finally, a question to George. The NAS Committee on Human Rights is part of, through Carol Corion's work, part of an international consortium of national academies of science. Have they taken this issue up, do you know? And if not, perhaps you could propose that they do so, because it is an international issue, as Mark has pointed out. What we're continuing to do undermines human rights everywhere. It undermines medical ethics everywhere, and it makes it an unsafer, a less safe world for us to do what we all want to do, which is help heal people.
I want to be mindful of going to Dr. Blanket and Dr. Sageman, then I'm going to tag Dr. Fens to talk about your issue of the habeas corpus, because just thinking out loud, in my involvement, and I think both Sandra and I have advised the attorneys on the habeas cases and on the military commissions. So I find that the attorneys are very absorbed by that, because the way that, and I'm not an attorney, but the way it plays out is different than it is in our federal and in our state system, the way the habeas corpus cases play out. And of course, they object to the commissions and the way that those rules have been written as sort of an extension of the court martials. So you think about why the JAG has acquitted itself as compared to the medical corps. Well, this is a basic issue. I mean, both the exercise of habeas corpus as well as what the laws are that led to, I mean, the commissions, the rules were not written until about 10 years ago by the White House as extensions of the UCMJ. I don't know that we have something quite the same that brings us to the forefront in our clinical work. But I just put that out there. But question to you now, Ron.
Yeah, just a clarification first, then I want to address the public health issue. The medical facility at Guantanamo, doctors, nurses, everybody else, is separate and distinct from the organizational entity that runs the prison. They don't even have much of a dotted line. They go up through different chains. Now, you still have to work together and all of that kind of thing, but it seems to me, and this is a vast oversimplification, that many, if not all of the medical problems, certainly most of the medical problems that exist are not generated by the medical system, distinct, separate over there, but by the prison administration who put in place various policies, and then the medics tend to get sucked in and don't know what to do about it if they object. That's part of the reason for the ombudsman, and then the trust issue, and we've discussed all of that. So the point of the Public Health Service, and oh, by the way, this could be blended nicely. You can have the medical care being given by Public Health Service officers while the support functions being done by the, actually it's the Navy that has the facility there and so forth. There's all sorts of ways that this could be carried out, and there are models for it already in existence. As I mentioned, Public Health Service already provides teams to the military. So that's something that I think Steve and others will grapple with and perhaps can come up with some reasonable recommendations. But I think it's certainly worthy of consideration.
Mark?
Yeah, from what I heard, a lot of people think it's maybe if we have better doctors, we won't have this problem anymore. Like, if we train them better or stuff like that. I told you at the beginning that being a child of Holocaust survivor, I always use that as a way to guide myself to see how I would react. Let's say I'm a concentration camp, inmate. Would I accept a Nazi concentration camp doctor as my physician? Probably not. I'm not really comparing the two. I'm just kind of using the extreme to kind of clarify some of the thoughts. It could be Albert Schweitzer, in uniform and great physician. I still would not. And so, just keep this in mind to kind of say, well, there's something wrong with the system if even great physician may not be trusted. Because in order to deliver medical care, it's not just having fantastic physician, it's also having patients who trust the physician. I mean, you don't have rapport, you don't have anything. And I want you to kind of keep that in mind, because I like to defend the physicians. I think most of them are kind of put in a very, very difficult situation, almost impossible situation, and that's what I think we should kind of structure a situation so we avoid this. That's all. Thanks.
Joe.
Well, it's interesting, in the context of the JAG officer who goes to court to get proper representation for their client, they're using the law in the service of the prisoner. I think what happens in the clinical context is it's not just in Gitmo, but I think it happens in hospitals. There's a kind of medicalization of the law, and what should be a competence hearing becomes a kind of in-house capacity determination, and the person is deprived due process rights unless the ethics committee sometimes gets involved and says, we got to go to court because what you're doing here, it's kind of a gray zone. Even though, Quinlan threw it back into the hospital, they want the ethics committee to make decisions. They don't want to make all decisions. The other thing is I think that there's a confusion about feeding tubes. In the context of a hunger strike, it is not a medical intervention. It's a political action on the part of a prisoner. And doctors can look at it and medicalize that as well. So you get a kind of a conspiracy of medicalization of both the law and medical acts together that leads to a kind of a false sense of we don't need the law here. We can do this ourselves. And I think that needs to be unpacked and the illogic of that demonstrated so that the doctors realize that at certain points that their patients are also prisoners who are also defendants that need the protection of the law as however it applies to the jurisdiction they're in.
Yeah, I just wanted to pick up this issue of habeas corpus and so on. I personally would never dream about talking about it in this country because it works in a slightly different way here to the UK, and I struggle enough with the UK law. So I'm not going to mention that. But I do think that, and it comes a bit about this conspiracy and medicalisation, but I do think that one of the reasons I keep talking about public health and the role of doctors to have a public health view as well as their individual patient-focused view is because that takes us into dealing with the right to health. And the right to health is a genuine and legitimate medical concern, and it allows us to look at what we can do. And I think that in terms of the first case that we talked about this morning, we could quite clearly see where the right to health had been breached. And so you could actually see where you would have expected doctors to be saying, stop, this is wrong, this is what we need to provide. And that, I think, without having to try to get doctors aware of the law that covers them, if they can understand some of those medical rights, then it allows them a different way into dealing with much the same kind of area.
Yes.
Hi, I'm Catherine Hawkins. I was previously with the Constitution Project. I had a question which is deals with the constraints of secrecy imposed on doctors by the military and intelligence services. How can you design any effective systems for whistleblowing, for consulting with other medical personnel about ethical questions, or for professional discipline if you can't discuss what happened?
Well, I can't discuss it. Yes, Catherine.
Just one part of that, the question of ethics. There's been some great suggestions and ideas here that we certainly need to go over and assess. And one of them is a thread of an idea about looking at the ethics of a particular situation in a detention setting. I think, Joe, you mentioned the similarity to ethics committees in hospitals, which are standard. And I wonder whether, I know that the Department of Defense has established an ethics committee, and when we've met with them, they told us of their interest in trying to introduce concepts of ethics to their standard operational procedure. I don't know whether what they have established is intended to function along the lines of what Joe Finns is talking about, or whether it has some other function, and how does it relate to what is actually going on with the detainees. I don't know if that's a fair question, Dr. Shamouf, at this point, because it's just started, I think. Is that?
No, it's
been in effect? Oh. Sit down.
I am certain that that's not the function of the Medical Ethics Subcommittee of the Defense Health Board for DOD. These are more issue-oriented and task-oriented, and we will answer certain tasks, and that's it. That's not the permanent sort of ethics board or commission or ombudsman for the DOD. To my knowledge, there is no such thing.
Catherine, yeah.
Yes, I work with Military Defense Counsel for the small number of detainees at Guantanamo who are actually currently in proceedings. All of the ones who are currently in proceedings are in capital cases in which they may be, receive the death sentence. Dr. Miles raised the issue of accountability, and there were questions about what have the state licensing boards done about doctors who were involved in earlier detainee treatment, interrogations, and lack of medical care. There have been several complaints brought against several medical personnel involved with what are known interrogations. I believe one of the boards responded, it's not our business because he wasn't actually practicing medicine because what he does wasn't practicing medicine. So there have been a number of cases brought that have just all fizzled out because people didn't want to have to deal with the issue of accountability because it makes them have to question their profession. I'm going to read to you one line from one briefing that was filed by Defense Counsel in one case. And this is all I can read to you. The definition of Mr. Al-Baluchi's observations and experiences as classified seriously damages the quality of his medical care and prevents meaningful rehabilitation from torture. See classified addendum. Observations and experiences refer to that person's observations and experiences while he was being interrogated in custody at a black site. Whether you believe he was tortured or not, he won't be able to describe those observations and experiences. The government claims to have an ownership in those observations and experiences. There is a circular problem here, whereas because he was tortured, he cannot get rehabilitation for his torture, and because he was tortured, he needs rehabilitation from his torture. So that's all I'm going to say, and I really think it's important that you all take this issue up.
Catherine, that does illustrate the dilemmas. Yes, Vivian.
Yeah, I don't have the answer to this, but something along the opportunity of like a FISA court, that is jurisdictionally established to have these conversations, so that this kind of information can be discussed. I mean, it pains me as a doctor that this individual's experience cannot be deconstructed and worked with because nobody can talk about it. So it's just PTSD on steroids. It just goes on and on and on. It's kind of it's a tautology without any relief.
I just wanted to comment on Dr. Lawrence's comment about system problem here. And I came here today having read through some of this material, wrote some questions for myself, and one of them was, what's the reason that a person who is suspected or convicted of being involved in a terrorist activity doesn't receive the same medical treatment as any other person accused or convicted of a serious felony or murder? And it seems that the answer is that there's parallel systems of both legal and medical care, certainly for detainees, and perhaps in the military to a greater extent than we're aware, but certainly for this group, and that this is a huge system problem that for which there is no transparency, and that we need great transparency, and that if the only thing we do from this meeting is make this really public, that there are these parallel systems within the care of individuals under the caretakership of members of the United States, wherever they may be, that this ought to be known.
I think that's a very important output of this group, is to bring transparency to what the circumstances are and to humanize them. I will add for your consideration that I testified to the Senate Judiciary Committee on July 24th with two other retired Army generals, a JAG Corps current, then a Navy JAG defending one of the detainees, and another expert. And the purpose, as I saw it, was in fact to bring some that kind of transparency to the process and decisions about what was happening in Guantanamo. I walked away feeling that that intent had in fact been overrun by the fear factor, and that the fear factor of having these people who were still considered enemies and still agents of asymmetrical warfare, and who at any point in time may commit another terrorist act, was going to override any consideration of what might be their humanity and what might lead to a different approach for handling them. And I think, from my perspective, as I've encountered this conversation very constructively, those politics are still at play here in the larger sense. And as I think, I forget, it was you, Bob, talked about what are our responsibilities as physicians when it comes to those kinds of enactment and support of human rights or civil rights. And I do think that it leads us then to wonder, do we stay in our lane or do we not stay in our lane? And what is our lane? What are the boundaries of that lane, which then become blurred as we think about public health issues, then become blurred as we engage people and wonder, are we advocates or mere objectives? Become blurred, or are these enemy or not for these people who have been detained and not been tried, and forces us into think about these fundamental, guidelines that have particularly, we've subscribed to in the course of our practice. So that's my little remark here. And I'm going to make a sort of put you a little bit on the spot, Ron, again, is I recall about 30 years ago you were the commander at Berlin, MEDAC, right? And were you not responsible from some of our last? What was your experience there in handling Mr. Hess?
Yeah, I was privileged to care for, I think, the last of the war criminals. Actually, he wasn't war criminal. Rudolf Hess was convicted of crimes against humanity, not war crimes, because none of you will recall, because most of you weren't alive, but he parachuted into Scotland in June of 1941, just before Germany attacked the Soviet Union. He had been in prison longer than I was alive. I was born in October of 1941, first in the Tower of London, then in Nuremberg, and then at Spandau. So he was the last prisoner there and managed to hang himself at age 93 while in prison because for just a minute, the warder who was with him, 24-hour line of sight and all of that, spoke to guards on the wall. He wandered into a shack on the grounds of Spandau and put an extension cord around his neck and did himself in. So, yeah, it goes back that far.
Other comments, observations, or George, Sandra?